or you can send a chat message if you're having any technical difficulties. You can mute and unmute yourself using the small button at the bottom of the screen that looks like a microphone. We do ask that everyone remains on mute when you're not speaking to reduce the background noise. Staff may mute you, but you can always unmute yourself. So you can use the chat function to send notes. It does send it out to everyone. It doesn't send it to a specific person, unfortunately. Please announce yourself when speaking. And if you'd like to speak during the meeting, please take a piece of paper and fold it in half and hold it up. The meeting facilitator will call on people holding up their paper to speak in turn. And at this time, I'll turn it back to David.
Okay, good afternoon, everyone. On the committee call this afternoon so far, we've accounted for Doctors Berenson, Haft, and Reedman. Is there anyone else that's on the call or virtually connected that is on the committee that haven't said they were on the line? So haven't announced. Did I miss anyone? So Dr. Pham is joining us. So good afternoon, Dr. Pham. Thank you for joining today. So let me first clarify that we should continue at this stage. So Dr. Reedman, your thoughts about how to progress from here? Should we move ahead? We have 4 members of the committee. Your thoughts would be appreciated.
I think we move forward. We know Patrick's not coming in. We know that Bard's going to be a little bit late. We're kind of missing Stacia and a couple of others, but I think that the important people are here.
Okay.
I think we go ahead. We know Stacia's calling in. She typically calls us 5 or 6 minutes late, so I think we go ahead and get started in the interest of time, and at least kind of get some of our, until we get to the meat of this. It'll take us that long to get into the meat of the conversation.
Very
I'll
good.
let you start off, David.
Wonderful, thank you. And again, as a reminder, we are focusing on the requirements gathering table. Alana, if you could bring that up. Our focus of attention will be centered on the areas that are shaded. We sent out an email asking that the Advisory Council Recommendation Committee members look closely at what's in these shaded areas, because that would be our focus point for tonight. Just as a reminder, this is a starting point and not an ending place. The work that we've been doing as a committee over the last several weeks was really to formulate areas, to identify areas related to primary care first that the Program Management Office can present to Cnmi for consideration of where we think that changes we would like to see made. And we've included some of those changes for discussion purposes only. And Dr. Haft will remind us in a moment about how this information will be used. And tonight we want to go through these areas and identify if there's information missing or information that needs to be changed. And if we go rapidly, if we get through it tonight, great. If not, we have next Tuesday set aside, evening at around the same time, to continue the discussion. We also want to capture any relevant feedback, because over the last several meetings, there have been some interesting discussion around items that we should think about for down the road, if you will, or as a next step. And we want to make sure we've captured all those in a different column. So we'll tee up what you see in the shaded area, collect feedback, and then if there's any relevant items to include as consideration for another time, we want to record that, and we'll work through this document. Now, before we get started, I would like to invite Dr. Haft to make a couple of comments, just as a reminder about what our end goal is for CMMI with this document, this requirements draft document that we're putting together, and remind everyone that we will be presenting this to the full advisory council and in August for their feedback. And Dr. Haft, if I could invite you to sort of summarize the discussion that's occurred virtually today, and where you and the email that you sent out last regarding that dialogue. It was a great dialogue and very interesting. And I thought you might want to, in case anyone has not had a chance to really digest the thread. So with that, I'll turn it over to you, Dr. Haff.
Yes, certainly. So I think to frame where we are now and where we're going, I would say that the great work that the subgroup has done on being able to look at primary care first and then make suggested changes in a parallel column, and the work that David and Melanie and MHCC has done to aggregate and get a consensus out of everyone's comments is a step in the direction that we need to go in order to be able to get to a place where CNMI is comfortable with submitting a proposal for track 3 to their leadership. So it's several steps along the way. This is one of those steps. This represents a part, but not the totality of what that discussion will be, because it will have to take multiple parts, as these things do over time. But this gets us to the step 1, where there's actually a proposal that can be begun to be pushed through the process of clearance at CNMI. So this step is clearly one where we're looking at what's in the document for primary care first, because it's a recognizable document for CMMI, and one that they said they need to have something that's more or less recognizable to facilitate the clearance process, so there are not too many nuances in it. But understanding also that it'll have to be blended with the totality of the MDPCP program. So it won't be yet another separate model. It'll be part of the continuous model of MDPCP, which is a state model within the total cost of care model. So there are many things that will be added, and this document here will not describe in any way, shape, or form a final RFA or participation agreement. It's just a step toward that. One of the things that came up in the discussion was our very, very thoughtful discussions about quality measures and what they should look like, and how they might differ from what's in the 4 corners of primary care first. I point to the fact that MDPCP has its own process already for developing quality measures, which is driven by a collaboration with state and CNMI and with input from the advisory council. So what we put in here will only be a placeholder at best, and I think there is consensus that where we are in primary care first, where we are in the nation, is not a place where anyone wants to wind up as a final place for how we measure quality in primary care or in healthcare in general. So there's work to be done there overall. But I just want to point that out so we don't get hung up on having to solve that very hoary problem of how best to measure quality in the work that we do in this or any other program in the deliberations that we have now. That will only be the best kind of a placeholder, and there will be at the end of the discussion today, if we get to that, I want to give you a couple of more thoughts and perhaps send out a document for other things that would be not in the 4 corners of what we're looking at now, but important issues that we'll have to address with CMMI. We appreciate that at the appropriate time, not now, but after we finish this work, to get this the subgroup and the advisory council's opinions about how best to address those other peripheral issues. So I'll just stop there.
Okay, thank you, Dr. Haft. And did anyone else from the committee join that I haven't mentioned their name? I do see Dr. Berkowitz, but are there others? Okay, so at this point, Dr. Riedman, do you want to review what's presented on the table for comments, changes, and suggestions? And you'll note that Alana will be keying in red any sort of changes that are proposed or dialogue you think we need to capture. So for those who are following, you'll see on screen, we're starting with the total monthly payment area.
So just real briefly before that, I do want to try to leave at least 5 minutes or more for Howard to give a summary at the very end of the meeting, so that the committee has a chance to think about his comments before our next meeting. So we'll definitely try to get to that before we leave. We'll finish, and we'll see what we get through the night. I just want to emphasize what both David and Howard said, and that is that I think that the goal of this initial draft is just to kind of get some thoughts and get the deadlines that we have to get some information to CNMI. But I don't want to lose track, and we've had this third column that we plan to keep open to add the comments that we've been excellent about all the things that we just mentioned, that we don't lose track of those, because we can certainly have time to go back and look at those and try to figure out how we get it back into our final recommendation. So this is a work in progress, and keep that in mind. So the first column, again, we discussed these things. I just want to go through the night and make sure that we're all on the same page. There's no other major thoughts on it. The comparison, as everyone knows, the first column is what the PCF program, or the Pine Care First program is, and then our thoughts on the second column. The first thing is about practices being paid to deliver advanced primary care. The two different payments that we've talked about, the PBP, which is the
population-based payment.
I'm sorry.
Population-based payment.
Yes. No, the piece, the PCP, and that is the number that is basically at risk, if you will. That's the number that's based on your quality measures and your illness burden score, the HCC score they're using, different for each patient, and summarized. That's what is basically at risk when we talk about the ups and downs. And then there's the $40, the fixed fee of $40.82. And there was some question that came up in our initial meeting, was whether that was enough or whether it was too much. I actually have a question along those lines I'd like to clarify for our full committee. Is one of the things that came up in our initial meeting was that enough, and where that number came from. And I'm not sure we really ever answered whether we know where that number came from and whether it's a realistic number. So I would suggest that I'll open it for comments on those things before we finish, but I would suggest that I would like to see that if we can get some background on where that number came from, and so the committee can really look at, and the full committee can decide, is it a reasonable number? And I'm sure other committee members would want to know where that number came from. So if we could do some research on that before our at least final meeting or full board meeting, that would be great. So any other comments under number one, any additions or suggestions?
Can I just ask a couple quick questions
Sure.
related to this? First of all, I know we mentioned that there will be a scale here and different degrees, but is there any 5 groups, but is there any sense of what the scale of this looks like? I mean, I think to your point of whether it's enough or what, just even a range or any sort of a spectrum on that, I think would be helpful. And the other thing I was going to ask is, does this include sort of IT and tele-related expenses, things like other additional costs like vaccines, ancillary services? Is that all sort of folded into a total payment, or is that separate?
No, my understanding is that it does not include any additional payments for infrastructure, Scott. And my vague sense of where they derived the number was that it wasn't a cost built up. It was based on some back of the envelope estimates of historical revenues.
And it's
Does it include telehealth? I'm sorry.
It does not. Obviously, it does not at this point, unless the agency decides to amend it. Which I don't know that they have enough data. I don't know that any of us have enough data at this point to really do a reliable quantitative estimate. They have some sense of what the volume of displaced or substituted services were for in-person versus telehealth, but I don't know that they have anything stable enough to really estimate it enough to price it out for future years. That may be a fool's errand.
Yeah, and I think the question too, as it relates to the amount assigned to each of the 4, in this case 5 tiers, which was determined by CNMI, if the RFA points out and provides the range, we don't have a good answer to the actuarial process, and that's something we can make a note of, because the RFA doesn't really give a good actuarial formula for that amount. It merely states what that amount is and the different levels. So Alana, if you could capture that at the bottom, that would be something we make sure we ask to get more information on as we go forward. Are there other comments regarding what's presented here?
No. Okay. In that case, so we'll try to answer those questions. I think it's certainly have it for the full committee.
Dr. Reedman and Dr. Berenson.
Yeah, I had a comment. I couldn't unmute my mute, but I have. I'm just doing some research now, trying to find out what the billing costs are for office visits and as it might apply to telehealth visits or telehealth communications. And the one study that actually has a definite number, it's from an academic health center, so it might be higher than it would be for a small practice, but it's over $20 just to bill for an office visit. So we are now having a visit code that is, half of it is going to be taken up by billing. And that's just a single bill. If there's co-payments involved, it's going to eat up the whole thing. If there was some way, I mean, I've just found this, if there was some way to reduce the low end of visits, like up through level 2, and then pay $60 or whatever the math would produce for levels 3 and above, it would be worthwhile. I mean, I have found that, I guess you probably know that there's now a check-in visit in Medicare that started in 2019. It's almost never billed. I think physicians have figured out that to get $14 costs more than $14. And so that is a very practical thing. I don't believe CMS has any idea, maybe they do, that creating a whole number of low volume, high volume, low dollar amount visits is self-defeating in a fee schedule. And so I just sort of would place a marker on that as to whether there's any way. It goes to Dr. Reedman's recommendation that we find out where this number came from. If it includes a lot of sort of low-level visits, it's self-defeating, I guess.
Yeah, Alana, can you add that underneath what's in red? And Dr. Berenson, you mentioned the study, I believe, and I didn't quite hear where you found
it. It came out of Duke. It was published last year. I can send you the reference. I just got it recent. I just found it recently. It was in JAMA.
Okay.
In fact, before, I'll find it and send it around right now as we're talking.
Very good. Thank you.
So the other thing about the $40 fee is that does not include the patient copay, which in primary care first, the practices that apply or indicate whether they are actually going to make an attempt to collect that. I don't think we need to include that here. We probably would in the application want to know, as practices transition from 2 to 3, what their intentions are about that. But it might, if you factor in the copay, which was actually the copay is factored out off what the real Medicare fee schedule would have dictated, not 20% of the $40. So it's a bit higher than that if a practice elects to collect the copays. I don't know on the PF in the primary care first applications how many actually said they were going to go after it. There would be administrative headaches for trying to calculate that, I think. But it's something to keep in mind that the payments could be more than $40.
My reaction would be that it's real important that be a copay and not a co-insurance that has to go through adjudication and then we bill it later. As long as there's a single fixed fee, everybody can know what it is and it can be paid at the time of service. If you had to wait for the reconciliation and then to be billed $20, that would eat up all of the money in billing fees.
Agreed. Dr. Reedman?
Okay.
Is there somebody on the line who's...
Hi, it's Stacia. I couldn't get in on Google Meets. My apologies. I've tried like 15 different times.
Oh my gosh. Sorry to hear, but thank you for joining us.
Yes, so I don't know how to raise my hand. I'll try not to be obnoxious.
Don't be bashful either.
Okay, thank you.
Sure. Dr. Reedman.
Got through the first agenda item. I'm not sure when Stacia came in, but we were talking about the the fees and particularly the $40 and where that number came from and how realistic that is. And we had some good comments on that. So unless you have some thoughts on that first item, I think we'll move forward to the second item, which is the performance-based adjustment. I'm sorry.
You know, the only comments that I would have, and I did send it out to the group earlier, is that, and I mentioned it last time, I'm concerned if we don't have a trajectory of a rising population health fee and over a period of time horizon with a lowering of a visit fee. I'm not sure that's going to comport with what CMMI is looking for, differentiated track 3.
So let's scroll back up, Alana, and add that Stacey's comment beneath that. Okay.
And I think that the key is that number has to be realistic enough to support the practices, and obviously low enough that they have the incentive to reduce cost. I think that's the key. And I'm curious again what $40 means. Is that, and the comments so far have been that someone put a dartboard up and because I love when people put like 82 cents. I don't know who comes with 82 cents, but is that a realistic number? And I think that if we could have a basis of where it came from, it might help us to make that decision and make our recommendation. So actually, Melanie, you have a comment or something?
Well, so Chad actually posted a chat saying where the $40 came from. He said that this is from the RFA, the Primary Care First RFA. The payment amount is roughly equivalent to the 2018 Medicare fee-for-service payment for a level 2 E&M service, and is reflective of the care intensity of many primary care visits. It is a national number.
Okay.
So that's where the $40 came from.
All right.
And Chad, if you're on the line, I don't know if you wanted to expand on that, but you can message me and I can. He did say we should recommend a Maryland specific rate.
Okay. I would like to then think about that and maybe even open up to our full committee about if we can come up with a more reasonable number or a reasonable number. And it's certainly beyond my expertise to come up with that number, but I agree with Bob and a lot of the other comments that, again, it's $40 too low when you look at the administrative cost and the billing cost and everything else for seeing patients. So I think we'll move on from there. We have some good conversations, some good points, and we'll move on from that point to the number 2, unless anyone has anything else to add. Under number 2, the performance-based adjustments, the practices are motivated to reduce ambulatory and sensitive ED and hospital admissions, and reduce the cost of care while meeting quality and the experience of care thresholds. So I'd like to actually ask quickly to have, not to belabor our conversation today, but I've had some thoughts about this in the last couple of months, obviously along the lines, and we've already mentioned telemedicine. But one of the issues is that our group is looking at potentially, we've looked for years to try to figure out how to do after hours. And because of our geographic distribution and stuff, it's been very difficult to set up after hour clinics and stuff, other than our patients going to the ERs or the walk-in centers, et cetera. But we've looked at telemedicine as a real opportunity to improve the quality care to our patients, improve our hours, improve our availability to our patients. At the same time, it would and should dramatically cut back on our patients going to the ER after hours for visits, going to the walk-in centers where they all get a chest X-ray and they all get blood work and they get all that everything, because there's no responsibility for reducing the care there. So we look at the telemedicine as a real opportunity to potentially improve quality, cut down on ER visits, and the other things. Our concern is that there's so far no indication that telemedicine will be reimbursed at the way it is now, and for the problems it is now after the end of the year or past the COVID issue. So I don't know if the committee thinks it's worthwhile that we add in a comment about the importance we feel that there is in telemedicine in helping to reduce the ER visits and et cetera. But I would like to consider that we maybe include that as a recommendation, and I'd like the feedback from the committee on that point.
So Alana, you want to just put it as a placeholder while we seek comments from the committee? I don't know if Stacia, you'd like to weigh in. Could I invite you to make a comment?
So are you thinking about something beyond the fact that it's a covered benefit? I'm just trying to understand. Or are you trying to advocate for in this track CMS making it a permanent covered benefit post-COVID? I'm just not quite sure I'm tracking what you're advocating for. Yeah.
Yeah, what we're thinking is, certainly from our group, it has been surprisingly a real benefit for a lot of our patients, elderly patients. All the reasons I think people realize that telehealth can be very helpful, not having to come in the office. For the perfect example I use is you're following up for your blood sugars and giving me results. I can do that on the phone, and you can be at work even and not have to drive an hour to the office, take off. So I think telemedicine during office hours, even after the COVID crisis, is going to be very helpful for a lot of people. What we're thinking about, though, is that after hours, weekends, evenings, potentially doing having providers available to do telemedicine for our group and our patients after hours, so that instead of going to the walk-in center at 11 o'clock at night, they're calling us and doing a telemedicine visit. If we feel like that would really significantly reduce those potential, at least a fair amount of those ER visits and walk-in center visits, if we had the ability to continue to do that. Our concern about spending the effort and time and hiring individuals and physicians to do that is to do it and then find out that, as the implication has been, that the payers and Medicare are not going to cover telemedicine at the current level by the end of the year, it makes it concerning. And I'd like to see, then our group would like to see, and I think the healthcare system would benefit from long-term the ability for physicians to do telemedicine visits after hours and not just during hours. That it would be much more beneficial for us and the patients. That's kind of what I'm driving at.
Okay, so I'm not hearing any indications out of CMS that they intend to discontinue telemedicine post-COVID. I don't know if anybody else, Howard, you may be plugged in, but all indications from CMS is that they intend to continue that. I think your question about whether they will continue that at the same rate as face-to-face visits is a fair question. I think that there are, I don't know that they will necessarily do that at the same rate as face-to-face, but I think the train has left the station in terms of, are they going to walk back some of their old store and forward, and the origin of the patient can't be in their home. So my sense is that train has left the station. I would certainly invite others to weigh in with what they're hearing.
Yeah, there's a lot of questions, but Stacia, we'll have you on the line too. I guess my question to you is from Blue Cross, from Care First, would be: is that y'all's intention also, or do you have an answer to that, or are the payers?
We had permanent telemedicine before the COVID crisis, so that was already a covered benefit. That's not the issue. Now, what changed during COVID-19 is we waived member cost sharing. That I do not anticipate will continue, particularly given the large volume of self-insured accounts that we have. But we already covered telemedicine, so people could do that before.
Stacia, and I'm not sure it was from Blue Cross, from Care First, but there was telemedicine, but there were a lot of restrictions on, couldn't be a new problem, couldn't be this, a lot of other things. Is that not true for Blue Cross, for Care First? And again, will it continue with the same, where we can see patients for new problems, treat them for acute illnesses and stuff during the telemedicine, at least from your standpoint?
Yeah, I don't know that we've had those kind of restrictions because we've always had a video visit vendor as well. We think it's a more cost-effective setting of care. So I would not anticipate. We will certainly have changes about whether or not cost sharing is waived or not. That was now certainly for COVID-related care. That will stay in place consistent with federal requirements. But I'm not sure that was a barrier in our commercial market anyways.
So joining us is Dr. Barr, and if I could invite Dr. Berenson and Dr. Pham to make a comment.
Yeah, I'm actually, I looked up that previous study about administrative costs, which I put on the my chat box, simply because I'm trying to do a paper now on paying for telemedicine. And so this is very fresh in my mind. I think substitutes for office visits, telehealth visits that are substitutes would likely continue to be covered at a reasonable rate. Once you start talking about it taking place in the home, I think it raises some problems about potential high spending when you pay through a fee schedule. The bigger challenge is paying for phone calls, which Medicare now pays during COVID. They initially started at $14 and now they're paying $46, which makes perfect sense to get money out into doctors' hands during the COVID crisis, but to keep it at that kind of level, just for a 5-minute phone call, I think if I were wearing my Medicare hat, which I once had, I would be very nervous about maintaining that kind of payment. But if I reduced it back to $14, which is what the RBRBS fee schedule would peg it at, the administrative costs exceed the payment. So it strikes me that a lot of those telehealth services is exactly what a per beneficiary per month payment is supposed to cover. That's, I think, one of the points of moving away from visit-based care to a range of activities which is covered through a monthly capitation. So, so that would be my sense of that. If there's ever services that shouldn't be paid fee for service, it is a whole range of things with patients when they're in their home, which is, I admit completely that it's desirable to keep the patient out of the ER, but paying fee for service is problematic, is what I would say.
So,
So I would encourage us not to think of telemedicine and telephone calls in the same sentence.
yes. So if I could do two things, there's Dr. Pham had a comment, Ben, and then Scott, Dr. Berkowitz, but also to be mindful that we're straying a little bit. And Mike, you might want to, keep us, bring us back after everyone has a chance to comment on this. Dr. Pham.
Yeah, I just wanted to clarify, we're talking about, I just wanted to confirm, my understanding was that primary care first would have similar telehealth waivers, both would direct contracting or what the next gen ACOs had. Is that correct? Just because things like originating site statutory issues, that's not at the agency's discretion except through its waiver authority.
So the RFA, I'm doing a quick search on the RFA to see if there's any indication, and I don't see it. So maybe someone else has more knowledge at the moment, but I don't have an answer.
I don't mean to force us to stray. Just something to keep in mind. We shouldn't assume that the Maryland model will have access to the same waivers, and issues like originating site are statutory.
Yeah, and Alana, if you could put that in, and Dr. Haft,
could I interject this?
Yes, sure, please.
Because I think it's important. I mean, I don't think this is exactly on point, but it is. It is within the realm of this whole discussion. Is that HSCRC is seeking to expand on some of the telehealth waivers. That I think we could include that in a recommendation here that we would want that to be applied to the whatever waivers HSCRC could achieve should be applied to this program. That's all I would say.
That's a great point. Thank you, Ben. Dr. Berkowitz, and then we can move on.
If I was interpreting Dr. Berenson's comment in the email, I was going to say something similar. It looks like there's a lot of revenue that's tied to potentially 3 measures. And I just wanted to sort of call that out, whether we should be thinking about the potential outsized influence or impact of a single measure within that, and whether it's better to approach it either through quality improvement or other, a broader set of measures, but not too many.
Yes, good point. Thank you for that.
I'll pull us back into this, but I guess my only my reason for the comment was to be that the committee consider assuring that telemedicine has its place in this program because this has come up since basically the program was created. And I think that's the case, but we keep hearing it, or at least our group keeps hearing rumors that these things, services won't be covered potentially, and it sounds like that's not necessarily the case. So again, I think we've had some good comments on that. I'll move forward with the next item there is a performance-based potential, and it went away. So let me get my little piece of paper here, and I'll read it from there. The practices receive up to 34% upside and 10% downside penalty through adjustments based on a quality and utilization achievement improvement against national benchmarks. We've had that conversation. Does anybody have any comments about that? If not, the next item is the matrix of adjustments to the PBA will include a minimum 3 quality measures. We kind of discussed that align with the Maryland State Health Improvement Strategy. 1 measure of patient assessment and comprehensive care, the measures of the PQI elimination performance. So again, we've had some conversations. I think that goes back to, I think, that 3rd column, that this may be our recommendation going forward, at least for our initial comments. And then we've had a lot of comments and discussion about what may be better measures for quality, and we can certainly include those as we move forward. But for initial, unless someone has comments about that, the next item is the practices and track 3 will have already had MDPCP experience, eliminating the need for the year 1 adjustments, and the practitioner's CP will be adjusted as described above. So if there's no other comments on that, the next number 3 actually is, we didn't have any real significant difference between the PCF program and the track 3 for Maryland Primary Care program. So I'm going to move through that one unless there's comments, and the same with number 4, where we didn't really have any other recommendations other than those based on the primary care first. So again, any comments on that, certainly interrupt me. If not, we'll move to item number 5, which is the risk groups and the risk group 1 and 2. These measures were selected to be accountable, clinically meaningful, and aligned with CMS's and Maryland's broader quality measures. The measures include the patient experience survey, the controlling high blood pressure, diabetes, hemoglobin A1C, and colorectal cancer screening, and advanced care planning. I think for our initial comments, that I think that's where we are, but this is another column where we've already had the conversation about how we might improve on those quality measures and what we do that might be more meaningful. Again, I'm not sure there's any more comments on that tonight. We've had a lot of comments, and I will say that I briefly looked after David and I talked about 15 minutes for the meeting at some of the emails that went through today. I thought there were some real good comments, but I did not have a chance, so I apologize to anybody on those comments. And if I don't have that feedback, I was seeing patients today and hadn't had a chance to look at them. I will look, but some of those I think were directed at this item also. So I'll keep going unless there's any other comments on that. The utilization measures for the PBA calculation, the PQI hospital and ED utilization, we talked about that one. The quality gateway, patient experience, the PCF and or non-PCF reference population for diabetes, the A1C, which we kind of mentioned, what those measures are, and are those realistic measures. I think those are kind of standards. So I don't think we need any other comments to that, and unless anybody has any. Looking down to the groups, the risk group 3 and 4, 1 through 5, advanced care, it would be MIPS, the CQM, advanced care, and then year 2 to 5, but administered in year 1, the patient experience and comprehensive, the care survey tool, selected by the state to include the tier 5. So any other suggestions or comments on that tonight? If not,
can I just ask, does everyone start in group 1 and 2 and then progress to 3 and 4?
I don't think so. That's a takeaway. I have to take that away. I don't think that's how it works. I think it's no. I don't have an answer. Let us check on that.
Ben, did you have a comment on that? I saw you waving your hand. You're muted, Ben.
I don't
So-
know the formula, but I don't
So
know.
what that has to do with, if I can, so how primary care first allocates the funding is not purely by individual patient's HCC score. It aggregates kind of an average HCC score for a practice and then puts them into one of these groups and then pays them for everybody, whether they're a high HCC or low HCC, pays them that amount on a per beneficiary per month. What we've proposed is using the same HCC score matching that we use throughout the MDPCP program, which is already extant, that grades every patient and pays patient by patient. So that language there, we wouldn't have if we do as we suggested, we wouldn't have practice risk groups at all. It would be a non sequitur.
Okay. I think that if there's no other comments on that, I just had one comment about the reporting, and we've had these conversations before. I know that from everything I read that there is consensus amongst everyone, but from CMS to providers, that simplification of the reporting measures is critical. The administrative burden of trying to report some of these measures. I think at one point there was at least a 50-page quarterly report we were doing for each one of our sites, which we have 6 different sites, and it was incredibly burdensome. And we've gotten rid of a lot of that, but I don't know if we should put a comment in here too about that simplifying the administrative burden and simplifying the reporting, whatever that reporting is. That the committee feels that's a critical point. And I think everyone recognizes that. I think it'd probably be worthwhile putting it in writing and putting it in our report. I don't know if there's any other comments on that either. If not, hopefully everybody agrees with that. I think they did.
I would say that as we strive to become a multi-payer model, there is a need to balance administrative simplification with the need to have more payers engaged. And I can't specify exactly what the trade-off is, but I think it's unlikely that if to have broader private payer engagement, if it's absolutely written in stone that these are the quality measures we're going to use, and take it or leave it.
Yeah, Ben, I think that's a fair assessment. I certainly speaking for one of the payers we would want to have multi-payer alignment with. If this isn't aligned with quality measures by which our purchasers judge our merit, that creates problems for us.
Howard, did you have a comment? I think I saw.
Yeah, just a real quick comment. And again, it goes back to the measures piece. But first, I totally agree that a multi-payer alignment is essential, and it needs to be developed over time. And there's a number of both from CPC Plus and others groups around states that are working on multi-payer data aggregation and alignment. So that's essential. I do want to point out that we already have an MDPCP process for collecting measures. And it's a process that's done together. We do it together with the advisory council and the CNMI. So and we wouldn't likely have different measures for track 3 than we have for track 2 or other parts of MDPCP. So it would be, the whole state would be having the same measures, and they're driven by state priority according to the total cost of care contract. So it would not. What's here is not likely to float over. Stacey's point is what we should move toward is sort of universal alignment of among all payers, and I think that's the direction to go in. But this is just what we see here in terms of primary care first.
Gotcha.
It just can't apply to MDPCP anyway.
And to Scott's original question about these risk groups and the progression, it does say in the RFA that Medicare will assign based upon the HCC scores. So people could move risk scores through the course of the years that they're in the program, but it isn't a progression of 1 through 4 or 1 through 5.
Okay. All right. Any other comments on that? If not, we'll move down to care delivery under 6. Basically, the first item there is the same as the primary care first program. The same with the second item about flexibility, so I'm not going to read those. What we did comment on was that the difference between the SIP patients and that the complex tier 5 was felt included in the DPC program and eliminated the need for the SIP. If there's no other comments on that, I will move down to practices, participants, and her partners. The eligibility, obviously Maryland only on the first item. The second item is the same. The third item is the same. We kind of talked about it a minute ago, but the eligibility on the next one is the progression from track 2 to 3. And same for the following item. We were agreed on the item that it's in white using the 2015 certified electronic health record. Again, the next item, progression from track 2 to 3. And then the next one was meeting the requirements of the MDPCP participation agreement. And the next item was the last item on that was the same as the PCF program. So I'll give everyone a second to, I went through that pretty quickly, but a second to digest that and make sure there's no comments. If not, I don't see any white flags. So we will move to number 9. And we've got about, I'm gonna go through 9, I think. That actually gets us close to halfway. And then I'm going to give Howard about 5 minutes so we, in the interest of our time frame, he can discuss some of the issues he has. So this last one, 9 and 10, we'll do pretty quick. We'll get through that, and it will put us halfway through. And the 9 is says basically the practice shall provide comprehensive care for all attributed beneficiaries. And I think that is pretty straightforward. So I think if we can get through those 10, and we could probably get through the rest of this with our meeting next Tuesday and some more comments. I'm going to turn over to Howard to give a summary of some recent things he's discovered, and it'll also give us a chance, hopefully next meeting, to have some time to discuss Howard's comments. So if there's nothing else on the template for the night, I'm going to turn over to you, Howard.
Dr. Haff, are you there?
I am. Thank you.
Yes.
Thanks. So, always a lively discussion. I love it. So one I wanted to add that Cnmi, our colleagues, have communicated to us some other issues, even before they have had the opportunity to see this initial feedback. They said, please make sure that you address these things, and we know that they're not necessarily going to appear in a side-by-side comparison of primary care first, because they're unique issues that have to do just with Maryland. So there were 5 things that they want us to think about and be able to provide some opinion to make sure that they can react to that. The first is track 3 optional, or is it mandatory? Does it mean that everyone must go to track 3 and that there'll only be a track 3, that there'll only be a 1-track program? Or is it optional? Practices can stay in track 2 if they're small or don't want to move to whatever the issues are in track 3. The second was, and we talked about this before, the track 1 phase out. They want to make sure that we address a phase out of track 1. I think we've already talked about that. It was inevitable. It was planned to be phased out anyway. The third was total cost of care accountability, and that's I think the differentiation that we would make is whether it's accountable to utilization or accountable to reducing costs. And what that means. And differentially, that means if it's reducing costs, it means that practices would be held accountable to whatever the per beneficiary per month costs are for Maryland, holding them to a certain level, as opposed to being accountable for holding utilization to, or avoidable utilization, whatever that, wherever we land on that, to a certain level. The fourth was the roles of care transformation organizations in track 3, whether they would persist, whether they would be relevant or not relevant to track 3. And the last was, since in these other, neither in CPC Plus or in primary care first, there's any element of track transition. There's no way to go from one track to another in CPC Plus, and there's only one track in primary care first. To have language to talk about transitions from one track to another. What would be required? What are the minimum requirements, if there are requirements, to go from track 2 to track 3, for instance? Or is it simply optional? So just things that would not be in the four corners of the document that we have from his primary care first, but we should address those. I'll send them to David, to the co-chairs, so they can send them out so people can ruminate on them in advance of our next meeting.
Yeah, and are there other questions or comments from the members at this stage? So Dr. Pham, if you could, Dr. Riedman, if you could clarify for us the meeting start time next week, that would be helpful. And then there's a couple other just final items to bring up before we go. And you're muted, Dr. Riedman.
I'd actually like to go back to the 5:30 next week, and 5 o'clock next week, and then do 5 with the potential to go to 6:30 if we can, and hopefully we'd finish up early rather than starting at 5:30 and being pushed. I think we should certainly be able to get to the rest of our chart here, I think, pretty quickly next week. But I do want to have some conversations about where we're going, how we present this to the full committee, and also comments on Howard's suggestions. And I'd also like to have a chance to digest some of the comments that were made today and some emails and see if there's anything else we want to add. So I suggest we do 5, start at 5 next week and see what we can get through by 6 or 6:30, with 6:30 being the latest, if that's okay with everybody. And we'll get an email out to everyone. And then our plan would be that unless there's some pickup next week, that we would then get out this information and plan on the full committee meeting sometime, probably the third Tuesday or fourth Tuesday, whatever that is, of August, would be our plan to try to get moving forward. So any other comments on that, David or Howard? Or?
So yeah, I think we're thinking about the 18th in August for the full advisory committee. What we will ask, and we'll send out a reminder to everyone, is that the spreadsheet that Alana was keying into is available on Google Drive. And what we'd like to get everyone to take a few minutes and just go back over the areas that we covered tonight. We did go quickly, but we think there's been some conversation that allowed that. And if you note the items in red that Alana keyed in, or are there other elements that you think we should come back and revisit, please key that into the spreadsheet so we make sure we have an opportunity to vet that complete. And in addition, if you can look ahead to the items that are remaining and you have any comments or thoughts there as well, that too would be useful for us to know, and that would be first up on the agenda to talk about at next Tuesday's meeting. So just to reiterate, we would be meeting at 5 o'clock next week, and it's always helpful where there's technical challenges if folks can try to connect a little early. We know you're very busy, and that can pose challenges in and of itself to find that time. Melanie, did I miss anything from the operations side?
The only other thing is that we post the meeting summary from the prior meeting on the website. So if anybody, it's very high level. The Google Sheet, as David said, serves more for the detail of the meeting, but there is a very high level summary that's available to the public, and it's available in the same place that we put the meeting announcement phone number for the public.
And we'll send a reminder.
So,
Stacia.
Yeah, I'm terribly sorry, and I wish I could raise my white sheet, but you can't see me, so I can't. I'm having trouble getting past our firewall to get into the Google documents. Melanie, I know you sent the spreadsheet out just as an Excel spreadsheet. Would you mind having that distributed as well? Otherwise, I'm afraid we'll miss some pieces.
Yeah, great suggestion. Happy to, we'll send that out as well.
Thank you. Sorry to be a baby.
No worries. Dr.
So
Reed.
it is, no, I was saying it's 6:31, and so in the interest of, we're a minute over, but so if there's no other comments tonight, I think we'll try to end on time, and then we'll look forward to 5 o'clock next Tuesday. Okay.
Great.
All right. Thanks, everyone.
Thanks a lot, everyone.
Bye.
Bye now.
Thank you and good night.
See ya.
Melanie,
Yes.
I sent you something I thought maybe in the interest, I mean, it's